complaining and all that stuff, do it in a non-public setting, okay? And I'm not going to even pretend that you're never going to complain, because I remember how it was too, and I remember complaining, but when I was in school, we didn't have Facebook, so it was just kind of, we bitched and moaned to each other. So if you're going to do that, then just text each other back and forth and say how much you hate everything and how horrible it is and all that stuff. See, there you go. So you just get it out, and remember that we love you, and it's kind of and I've always said it's a mama-child relationship. That, you know, like right now, personally, I hate my brother. I do. It was a horrible Easter day. I hate my brother. So, you know how we do that with families, right? So I understand that there's going to be times when we are not going to be your favorite people on the planet. But underlying it all, you remember that we love you and we want you to be successful, right? Does everybody know that? Does everybody instinctively understand that, even if you get pissy? Okay? So I don't want to get any more emails or texts from the faculty saying, do you know what they're saying on Facebook? Let me tell you exactly what they're saying. Yeah, I don't really care, truthfully. Okay? But just be careful about that. So 2 days back, so those of you who said that you felt like you had 12 days in a row or some ungodly thing, you know, then you have 2 days back. So you can't complain now. You have to find something else to complain about. And you're probably going to complain about what I give you to do on Friday, because you're going to say, this is just busy work. But it's stuff that, and it does look like busy work because it's a bunch of papers, but it should be something that you're going to learn from for the future, okay? Because I'm going to be having you do some pathophysiologies on some of this OB stuff. And you're going to see that stuff again. It's not going to be something you're never going to see, okay? Do you think you can maybe handle that? And then you can do it at home in your pajamas, and you'll be fine.
Life was always good in pajamas.
They're not stuff that's going to be on the test. On my test, some of them are for the next unit. But, yeah, but it's stuff that you may see on boards, and I really want you to understand this stuff, okay? So does everybody understand that?
Yes.
So when you go home and you say, this is just busy work, you're going to, in the back of your mind, even though it's coming out of your mouth, in the back of your mind, you're saying that I know she's doing this because she wants us to learn, right? Okay. So today we're going to try to muddle through delivery. Yes, dear. Yes. The zoo. Yes, that kind of snuck up on me, didn't it? May the 5th. Real quickly, and I'll bring this up again because I will have you sign up for animals by that day, but I'll tell you a little bit about it in case you have family that is going to want to go to the zoo. If you have kids, most of the time the schools will let them out to go with you as a activity, as a school activity. May the 5th is our zoo activity. We will be there at 8:45 at Ashford Zoo. You drive by yourself. It is a haul, but it's worth it. I promise you it's worth it. There will be one person at least in this room that thinks it's not, but I promise you it is. It gets us out of this room. It gets us in the fresh air. And I will have something for you to actually do that day. It's not just to go see the animals and have fun, okay? We will see the animals and have fun, but there is actually a purpose to this. You get in free. You do not pay to get in because it's a school thing. But anybody that you bring with you, and I don't care how many people you bring with you. You can bring 25 children as long as you have an adult to watch them, because you are going to be mine for at least 3 of the first hours that we're there, okay? And so if any of your kids are like Dan was when he was little, you know, we stayed at each exhibit for like 2 minutes, and then we were moving to the next one. I mean, you could barely see the animals walking because we were moving on to the next thing. So they don't like to stand, and you are going to have to stand at your exhibit or sit at your exhibit for about 45 minutes minimum observing. So if you're going to bring kids, just make sure you have another adult with you, or you have older kids who are willing to sit there with you. All right? Does that make sense? They do have to pay to get in, though. I can't pay for them to get in as well. Will have you for till noon, and then you can either leave and go home, or you can stay and enjoy the rest of the day at the zoo. Okay, hopefully it's going to be a beautiful day. In the 10 plus years we've been doing this, I think there's only been once when we couldn't go because it was monsooning. So hopefully it'll be a pretty day. It's a Friday, and we can get out and breathe some fresh air, some nice pollen.
What is the rain plan?
I'll tell you, I can't. You'll have to go online and see. I don't know off the top of my head, but I can go online and see.
What is the rain plan, or how are we going to be notified if, God forbid, it gets canceled?
If, God forbid, we will decide the day before, so we won't have this wait until the last minute. We'll just look at the weather and see. If it does rain, we'll be here. We'll meet here, and we'll have some other kind of activity to do. But, okay? Does that sound good? Be thinking, this is something, too, that they've done a few years to raise money for SNA. They made sandwiches one year, and they also did, they got orders up and went to wherever, Jimmy John's or somewhere, not Jimmy John's, but one of those sub places, and got sandwiches for people, and they usually will give money, like half of it back to your club or whatever. So that might be something you want to do, because food at the Ashburn Zoo is very expensive. So if you want to do something like that, that'd be awesome, but you don't have to. So whoever.
I think we decided on everybody bring their own sandwiches and we all do a picnic together.
Yeah, that's fine. Yeah, that's fine. Good deal. Did everybody see April, the giraffe, delivered her baby? I swore for a long time that the giraffe was not pregnant, but apparently she was. So she delivered.
They just had her, they didn't do a correct ultrasound to see her.
Well, I learned, the only thing I've learned in this is, one, how people can get captivated by something like that. And number two, that apparently their uterus is so thick that they can't actually see through with ultrasound. So they're guessing. So they're guessing at what's going on.
Based on what she had to say.
Yes. Based on when she last had her period.
Yeah.
So, what was it? 6 feet tall and 150 some pounds or something big. Those are big babies. Yeah. God bless her. Okay, so we're gonna talk about labor today and abnormal labor. So the first thing I want us to talk about is how the baby comes down the birth canal, because we ended with medications, right? We talked about the different medications that we can use during labor for pain relief, correct? We talked about epidurals and all that fun stuff. Okay. What is the biggest thing to remember, too, with an epidural? Fluids, IV fluids. You bolus, because they will drop their blood pressure very, very quickly. And if you've got a mother who, or you're watching her on the monitor and the baby's heart rate starts descending after you've given her a narcotic like Stadol, fetal depression, is one of the common side effects. What can you give?
Narcan.
You can reverse it, right? We can give Narcan. So that's some important things to remember. All right, so there are 7 cardinal movements as the baby is coming down the birth canal. And there's a picture that I put on your Facebook, on your Blackboard slide that has the different movements that the baby is coming down. The easiest way to remember it is with this little mnemonic over here. Don't forget, I enjoy expensive equipment. Okay? So the first thing it does is not up there. The first thing it does is with the E, that it engages. Because remember, the baby has to be engaged before it works its way up down the birth canal. That's not up there, but if you want to put it in parentheses, you can. The second thing is that the baby has to descend, then it flexes, it stretches out, then it internally rotates, then it extends, then it externally rotates, and then expulsion. And what I want us to do is watch this little animation on these 7 cardinal movements, and then I'm going to crawl up here on this table, and we're going to deliver our baby.
Somebody needs to get that on video, not
It usually ends up on Facebook. It does. Let me get my picture up. Make sure this is coming up, and I'll turn it on. Okay, here we go.
Prostaglandins, which soften the cervix, and oxytocin, which triggers the uterine muscles to contract. True labor contractions are rhythmic and painful and grow consistently stronger. As the long vertical muscle bands of the uterus tighten, they pull the cervix open. The strong muscles at the top of the uterus push down and release, guiding your baby toward the cervix. The mucus plug, a collection of thickened cervical mucus that sealed your cervix shut for 9 months, may be expelled days before or in the midst of labor. When the amniotic sac ruptures, your water has broken. It can feel like a trickle or a gush of fluid. Your cervix will begin opening and thinning, known as dilation and effacement. Once you reach about 4 centimeters, your body will move into active labor. In active labor, contractions become stronger and closer together. At 8 centimeters, you enter what many consider the most painful part of labor, transition. By 10 centimeters, you're fully dilated and may feel the urge to push. This is your signal that the second stage of labor has begun. Your baby will move down with each contraction. The 3 separate soft bones on his head will temporarily overlap so he can pass through the snug birth canal. Your baby's scalp will come into view. When the widest part of his head is visible, your baby is crowning. With several more pushes, your baby's face, shoulders, and body will emerge. In the third and final stage of labor, your placenta detaches and is expelled. With your baby's first breath, the incredible journey of birth is complete.
Okay, so I want you to see he's descending, right? That's what she was talking about, how he comes down the birth canal.
As the long vertical muscle bands of the uterus
and then he
tighten, they pull the
stretches out. I
cervix
want you to see
open.
how he's
The strong
flexing.
muscles at the top of the
And then
uterus
he has
push
to
down and
internally
release,
rotate,
guiding your baby toward the cervix.
stretches out,
The mucus
and then
plug, a
externally
collection of
rotates.
thickened cervical mucus that sealed your
See if you
cervix
can see
shut for
the
9
different
months,
movements.
may be expelled days before or in the midst of labor. When the amniotic sac ruptures, your water has broken. It can feel like a trickle or a gush of fluid. Your cervix will begin opening and thinning, known as dilation and effacement. Once you reach about 4 centimeters, your body will move into active labor. In active labor, contractions become stronger and closer together. At 8 centimeters, you enter what many consider the most painful part of labor, transition. By 10 centimeters, you're fully dilated and may feel the urge to push. This is your signal that the second stage of labor has begun. Your baby will move down with each contraction. The 3 separate soft bones on his head will temporarily overlap so he can pass through the snug birth canal. Your baby's scalp will come into view. When the widest part of his head is visible, your baby is crowning.
He turns,
With several more pushes, your baby's face, shoulders, and
and then
body
he
will
flips
emerge.
again. He externally rotates.
In the third and final stage of
Everybody see
labor,
that?
your placenta detaches and
Why
is
do you
expelled.
think
With
he
your
has to
baby's
do that?
first breath, the incredible journey of birth is complete.
Okay, he does do that. But what else is he up to? What else is he doing? Yeah, so the reason that he has to turn and flip is because you've got 2 very wide parts. You've got the shoulders and you've got the hips. So when he internally rotates, so he's flexed, he's stretched out, he flexes, he stretches out. When he flips that first time, he has to get his shoulders out past the pelvis. And then he goes a little bit more, right? goes a little bit more, he extends himself out, and then to birth him, he kind of flips this way. So he externally rotates, and that's because he had to get his hips through the pelvis before he comes out. Does that make sense? So he internally rotates, and then he externally rotates. So internal rotation, he flips on his side, and then he ends up flipping back on his back. And again, it's just because he has to get those very big parts of him through that birth canal. Okay? How do you know when the umbilical cord is getting ready to be born? Have you seen that in labor? Okay, she felt like the urge to push more because we said contractions are continuing, right? Contractions are continuing. And then what else is happening? The placenta is detaching, which that's what the contractions are. So when the placenta is getting ready to be born, the cord lengthens, you see more of the cord coming out, and you see a rise in the fundus of the uterus. It's kind of like a globular rise. And that's because that placenta is detaching itself and coming out. Okay? So there's three things. There's a gush of blood, a lengthening of the cord, and then a rise in the fundus of the uterus. Those are the three things that tell me that the placenta is getting ready to be born.
So does that usually happen like right after? Like really quickly after baby's born?
It's supposed to be born within an hour. If it's not, then it's considered retained.
Okay, because mine is old.
Yes. Woo!
Right.
Okay. If I had to get that down there and get back up there. Okay. All right, so let's go through it on the mannequin, and then we're going to talk about some other problems. It used to be a lot easier years ago when I did this. Oh, Lord, okay. All right, so let me take this down so you can see first off, what are we looking at? So this is the internal, here in the back, we're going to stand up again. This is the internal musculature of the pelvis. Okay, does everybody see that? Okay. It always looks so great. So here, this is what is doing a lot of this work, these pelvic muscles. So you see that the pelvis does not look that big. It's not actually that big to get this baby's head through. So in that animation, what did you see? His head, the fontanelles, remember they mold, they have to overlap in order for that head to get through. Okay? So if I put this back up, okay? All right. So I'll put this back up. So the first thing that you're going to see is the baby is going to descend into the birth canal. So it's descending down, and you know this because you're actually you're checking the baby. So it's descending into the birth canal, okay? You feel him crowning, and that's what she talked about on that animation. You actually know that the baby is crowning. Then he has to turn. Actually, let me do it this way. Yeah. So then the next thing he has to do is he has to, remember, don't forget, he flexes out because he's trying to push himself out. So he flexes out, and then he has to internally rotate in order to get these shoulders through this pelvis, because this is the tallest part of the baby and the tallest part of the pelvis. So he internally rotates, okay? What's the next step? Extension. So he comes out, his head is delivered, he comes out like this, okay? Then what does he have to do? See, he's still on his side, right? But now we have to externally rotate, and this is all, You almost don't even really see it because it's kind of almost in one motion. He externally rotates, and then he's expulsed. Okay? So out he comes. All right, now, you have this baby that's born. Okay? Now, here's my placenta. Okay, so here's the baby, and what are they going to do first? Well, the first thing they're going to do is they're going to suction, right? Even when his head is delivered, the first thing they're going to do is suction the nose and the mouth, or the mouth and the nose, okay? And remember, if the fluid was green, what are we going to do? We're going to have respiratory in the room so that they can deep suction that baby, because we don't want him to have swallowed any meconium, because remember, his little chest is an accordion, okay? So now we're going to cut this cord, right? We're going to clamp, 2 clamps, and we're going to cut this cord. So now baby is taken off, right? Where's he go?
Mama's chest.
Mama's chest, or to get clean, they're going to weigh him real quick, right? They're going to weigh him. They're going to see, make sure he's okay, and then they can put him on Mama's chest. And she's gooing and goshing and thinking how wonderful everything was until those contractions start again. Okay? So the contractions start again. So the first thing you're going to see when you know the placenta is getting ready to be delivered is a gush of blood. Okay? A gush of blood, a lengthening of the cord, and then you're going to see the fundus of the placenta, or the fundus of the uterus rise up. It's rising up. And as it's rising up, it's breaking apart from those villi, and then the placenta is born. Now, what are they going to do when this placenta is born?
Inspect it.
They're going to inspect it. They're going to weigh it. They're going to look at it. They're going to flip it around. They're going to make sure that it has all of its parts, all of its pieces, because one of the problems postpartum that we can face is retained placental fragments, and then they will continue to bleed over and over and over again. Okay? So you want to make sure that all of the parts are there. Has anybody had a chance to hold a placenta? A couple of you have. Those of you who haven't been in labor yet, that's one of the things I want you to ask them. Say, I want to hold it. I want to play with it. They're going to just put it in a bucket. That's all it does is drop down into a bucket. And, of course, if they want to take it home with them, they can. That's okay. Everybody understands that. I'm sure you talked about that with Miss Walker. It's a cultural thing, and that's not something we want to be away from. But they will let you hold it and look at it, flip it around, and all that kind of stuff. It's kind of like a big piece of liver, a big clot. Okay? And then you can see if you have all the pieces. They're also going to look at this cord, right? They're going to make sure that there are what? 3 vessels. So what? 2 arteries and 1 vein. 2 arteries and 1 vein. They're going to look at him, but they're also going to look at the umbilical cord itself to make sure that all the pieces are there. Because if we have missing vessels, we can have a lot of problems. We all talked about that too already? Okay, good. All right, so let's talk about, I'm just going to keep on sitting up here. So if you've got your PowerPoints, we're going to talk about dystocia in just a second. We're going to need... Yes, baby.
Whenever I watched the birth, I can't remember if it was before or after, but the doctor pressed down on her stomach and all these clots and blood came out. Is that part of the placenta?
It is. It's part of the placenta. It's part of all that blood that's been sitting inside. But remember, what is the worst thing you can do? Pull. We are not going to pull on the cord. Definitely not going to pull on the cord. Okay. All right, so the next slide that you have talks about the 3rd stage of labor, which is about placental separation, and it talks about the things that I just told you about. The globular-shaped uterus, the rise in the fundus. Does everybody see that? And I put a little picture of the placenta on there. Does anybody have any questions about any of that? Pretty self-explanatory. Is good. All my PowerPoint slides are now out of rack. Okay. The fourth stage of labor. Some people don't realize or think about that. They always think about 3 stages of labor. There's actually 4. And the fourth stage of labor is that 1 to 4 hours after birth when things are happening. The mother's hemodynamic status is very important at that point. There's typically a blood loss of about 200 to 500 milliliters of fluid with a normal birth. Which doesn't seem like a lot, but it can be a lot if she is anemic or she has any other medical history. That can be a big deal. If you've got somebody, for example, who had preeclampsia or something like that, then that can be significant. That change in blood pressure, that change in volume can cause a lot of issues. So you have to closely monitor their blood pressure, their pulse pressure, looking for tachycardia. All right, the reason I wanted to sit up here is because in just a second I'm going to let you actually feel for the baby, because we're getting ready to talk about dystocia. And the slide that you have for dystocia is just a general definition of dystocia. We're going to talk about the different things that can cause dystocia. Remember when I started this unit, we talked about the P's, the passenger, the passageway, remember all those, the powers. Okay, so we're going to talk about all the different things that can cause dystocia, and then I'm going to put the baby in a position, a dystocia position, and see if you can determine what it is. All right, so just the term dystocia is a long, difficult, or abnormal labor. Long, difficult, or abnormal labor. Okay, it's pretty generic. So let's talk about the first thing we're going to talk about is the, make sure I'm on the right slide here, dysfunctional labor patterns. Is that the next slide that you got after dystocia? Dysfunctional labor patterns. Okay. All right, so we have hypertonic and hypotonic labor patterns. Do you remember that I sent around, when I was sending around all the different strips, remember the different strips? And there was one that they had gotten an epidural and the contractions were coming really close together. Y'all remember that? Okay, that is considered hypertonic. So hypertonic labor, hypertonic contractions means that and I remember I talked about the pacemaker, where the labor starts at the top and it has to trickle its way down. And I said at that time that we would talk about dystocia and hypertonic. That means that the pacemaker point is starting in the middle of the cervix, in the middle of where it should be. Okay, so instead of starting at the top and trickling its way down to force that baby downward, it's starting in the middle. So those contractions are coming too close together. Now, it can be because we have given them too much Pitocin. We started it, and that was actually the strip, it was the Pitocin strip. So we've given them too much Pitocin, and the contractions come too close together. What would you as the nurse do in that instance? Slow it down or stop it. If you've got a mother who's in extreme pain because she's not having a resting period between those contractions, and it's, she's not having any relief, then you need to stop it, totally stop it. And then we would gradually increase the Pitocin again. Okay? Hypertonic contractions occur with mothers who this is their first baby and they're very anxious, and you can't get them to relax and to control their contractions. So they're very anxious, their anxiety level is really high, and you can't get them to relax, you can't get them to relieve that anxiety. They're not doing anything. They're not being effective because it's starting in the middle. So they're not being effective on the progression of labor, on the dilation, effacement, and the movement of the baby, because they're not starting up far enough. Okay? If you've got a mother who is anxious, who's very, very anxious, what can you do?
Breathing techniques.
Breathing techniques, calm environment. Do you see those signs that you can put on the door that says, check with nurse before you enter? Those are great signs, right? You don't need the whole church in there watching you labor. You really don't. Okay, calm environment. You can give medications, exactly. This is that time. If they haven't been sleeping and they're exhausted and you know it's going to be a while before that baby's born, knock them out. Let them sleep. Close the blinds, turn off the lights, put on soothing music. Let them sleep. Because then, when they wake up, that pattern is going to be more effective. Right now, it's not effective. A warm tub might help. You can. Remember we talked about the aderatics where you can give pain medicine plus something else at the same time? You could give an anti-anxiety, but you want to be real careful about the side effects for the baby. Visceral's one, yeah, that you can give. Okay? All right, so whatever the problem is, whether it's Pitocin, anxiety, whatever, we need to get that under control so that we can get that pacemaker point back at the top of the uterus, top to work its way down. Okay? Then you have the opposite problem. You have hypotonic contractions, where the initial progress was normal, but for some reason it stopped. It could be due to a full bladder. Women who have epidurals don't often remember or know that their bladder is full, so they don't know to go to the bathroom. So we are going to take them to the bathroom every couple of hours. You need to say, we need to go to the bathroom, let's get up and go to the bathroom. Okay? They may not feel it, and we want them to know that they've got to go empty that bladder, because that's the biggest main cause of hypotonic contraction. An epidural given too early. You don't want to give an epidural in that first latent phase of labor because they're not far enough along, and it can slow contractions down. No, you don't want to give it early. Yeah, definitely don't want to give it too early because it will slow that labor down, and then you're going to have an issue. Okay. Baby, they are hypotonic because the baby has turned in the wrong direction. It's not facing down or in that occiput anterior position that is ideal for labor. We talked about that. Remember, the OA position is the best position to be in. Maybe he flipped and he's not in a good position. And whatever position he's in has now made it impossible for that uterus to contract. So whatever the cause, again, we need to fix it. So the bladder distension is easy, right? Get them up and go to the bathroom. If they say, I can't pee, then you do an in and out cath. Just in and out cath. But you don't want to do that too frequently, right? Because the more you do that, the more you're risking giving putting bacteria up in that canal. So you want to make sure that you don't in and out cath too much. Walk them to the bathroom. Just get them up and walk them to the bathroom. If it is an epidural, you may have to stop that epidural. You may have to stop the flow of the numbing medicine, the fluid, whatever is the pain medicine, so you can get those contractions back. So whatever it is, and sometimes you may actually at this point have to give them Pitocin to augment it back, to get them going again. Okay. All right. So let's talk about the fetal causes. Okay, that should be your next slide, the passenger. The next slide. My slides are kind of out of whack right now. Okay, so the passenger. So who is the passenger?
The baby.
The baby. So there are three things that could be wrong with the passenger, and you've got pictures on one of your slides of how he's coming down. So the first thing is cephalopelvic disproportion, CPD, which is what I just said a minute ago, that he is in the wrong position or he's too big to fit down the birth canal. Now, at the very beginning of this unit, we talked about the different sizes of the pelvis, right? And we said that there's certain pelvic sizes that are not conducive to labor, correct? So if you've got a mother who did not have good prenatal care, you may not know what size her pelvis is until it's too late. So now the baby's gotten engaged, it's gotten down into that birth canal, and it can't go anywhere because the pelvis is too small. Or you've got a baby who is being born to a diabetic mother or something like that, and the baby's too big. Maybe the baby's just too big. He's macroscomic, so he's too big to get to the birth canal. Whatever the cause, he is, when you think about the word cephalopelvic disproportion, the head and the pelvis are not in proportion. So cephalo, right, head, pelvic, and then disproportion. They are not able to, they're not fitting together correctly. Okay? Malposition means that they're turned wrong. Typically, it's that OP position, either ROP or LOP. Women that have dystocia due to position often complain of back labor. And what can we do for women who have back labor? Remember? Get them up on all fours. Get them up on all fours. It drops that gravid uterus down, and it causes the baby, hopefully, that baby to flip. They can do some rocking back and forth, kind of sloshing around in there and getting to twist around and move. If worse comes to worse, the physician can try to turn him around a little bit. Now, you're not going to be able to go from breech to cephalic. You can't do that, but you can reach up in there and like flip him over. Now, that's very painful, right? And it can cause a lot of risk. You can have some lacerations and some tears of the cervix and the uterus, so you got to be very careful. But they can reach up in there and try to flip him around a little bit. And then the second thing that causes dystocia is presentation. So he's either a brow presentation, a face presentation, and those end up being a cesarean section. Those end up being a C-section because, of course, if they are in a transverse position or a strange position, breech, something like that, then they're not going to be able to deliver that baby. Okay. So most commonly, those will be C-section. If it's a face presentation or brow presentation, remember their little faces that have a lot of edema, bruising, lacerations. They're going to look pitiful. They look like they've been in a bar fight. Okay? All right, so the next thing is alterations in the passageway. The passageway. Okay, so the alterations in the pelvic structure, and we've already talked about what are the types of pelvis that are the best to deliver. Gynecoid and anthropoid. Gynecoid, anthropoid. Android and, what's your other one? Platyploid, like the platypus, are not capable of delivery. So pelvic dystocia, the shape of your pelvis, but you can also have a soft tissue dystocia. And a soft tissue dystocia, the most common soft tissue dystocia that blocks the passageway is a full bladder. Again, we just talked about that, right? That causes them to, those contractions to go hypotonic, and so you need to get them up to go to the bathroom. Another thing that can cause a soft tissue dystocia, where they can't push past it to deliver, is a fibroid tumor, or the placenta has come apart, either placenta previa, where it's too low, or an abruption. So the placenta is blocking the way. So there's a couple of different problems there. An abruption, placenta previa or abruption. And if you continue to labor that mother against a soft tissue dystocia, against something that it cannot push past, then it can cause the uterus to rupture. So you do not want, if you feel an obstruction of some kind, you do not want them to push past it. Now, there's some things that they can do to alter what we call dystocia. And somebody asked about this back at the beginning. There's a process or procedure called aversion. Aversion is when you change the baby totally in position from a breech to cephalic or transverse to cephalic. There's some things, though, that you absolutely have to have in place in order for the physician to do aversion. The first thing is that they have to be at least 36 weeks. The reason for that is because there is such a high risk of preterm labor with aversion that you don't want them too early. Okay, so at least 36 weeks. They have to have a reactive non-stress test. So that non-stress test has to be reactive. You have to have some accelerations, some movement, and the breech or the shoulder cannot be engaged. And I said that originally, once it's engaged, you're up the creek. It's done. It's over. It's stuck. Okay, so it's either C-section or you deliver it the way it is. So the breech cannot be engaged. So you have to have so many weeks. They have to have a reactive non-stress test, and the breech cannot be engaged. What they will do to these women is they will give them a sub-Q injection of terbutaline, and that drug, terbutaline. That is one of the drugs, hopefully, that Ms. Walker talks about in preterm labor. Never heard of it? Okay. So terbutane or terbutaline is a drug that they give to cause the uterus to relax. They give it a lot in preterm labor. There's actually terbutaline pumps, like a insulin pump. That's exactly what it looks like. She did talk about that. Good. Yeah. Okay. So relaxing. So terbutaline is one of the names of the drugs, and or you may say it's called terbutane. So it's just two different ways. But it relaxes the uterus because we want that uterus to be relaxed before we start moving it around, right? If it's agitated or aggravated, then it's going to put us in preterm labor a lot quicker. So, okay. Now, the thing about this is, and this is why I did not choose to do this with Ben. He was breech from the very beginning. He was high breech. He never dropped. And she offered me aversion. I said, absolutely not, because it's risky. Number one, it's very risky. And number two, it's painful, extremely painful. If you can imagine, you've got them sticking one hand up inside and then one hand on the outer part of the woman, and they're literally forcing that baby, pushing him up and forcing him down into a new position. And they can flip back. You could go through this whole procedure with the risk of the preterm labor, with the pain and all that stuff, and then you go back for your next checkup, and that baby just loved being butt down, and he flipped back again. So it's not, in my opinion, it's not worth it. My C-section was not bad. I'd have a C-section 25 times over other than go through this. So it's a decision that everybody has to make on their own. I just think it's very risky personally. Okay. But does everybody understand the things that you have to do for it? Have to be a certain time, have to be in reactive fetal heart rate, and then you have to have it not engaged. The other thing that you can do to help with a dystocia situation is either forceps or vacuum. Has anybody seen forceps or vacuum used yet? Okay, a couple of you have. I've got a couple of different types of vacuums that you guys can pass around if you want to. This is the old kind of vacuum. What you would do is you hook this up to wall suction, like this, and then you stick this on the top of his head, and you slowly increase the suction on the wall, and you're pulling at the same time, so you're pulling him out. Okay, so this is the old kind, and it makes you purr, doesn't it? And then you have this kind, which is a smaller type. You reach up in there, stick this on his head, and then you pump it up, And you can actually stick this to yourself if you really want to. You might have to have somebody else do it for you, but okay. And it sticks to his little head. Okay. And then you use this to pull it out. Okay. That's one way to do it. And then you can release the vacuum. There's 2 of those. This is the one that a lot of hospitals are using now. Similar to the pink one. You still hook it up to wall suction, but you can actually look at the gauge here to monitor how much suction pressure you're using. Okay, it's handheld. So you do it like that. Actually, you don't even have to use the wall suction if you don't want to, because it'll do it this way. Okay, and then you use this to pull it out. Yes, let's talk about the risk of vacuum and forceps. Do you remember when you did post-newborn assessment, there were 2 types of problems that can occur that you look for, cephalhematoma and caput succedaneum. Do y'all remember those?
What was the second one?
Cephalhematoma, okay, and caput succedaneum, CAPUT, caput succedaneum. Y'all remember those, what you're looking at? Caput, let's talk about cephalhematoma. Cephalhematoma is a collection of blood that does not cross the suture line. So a collection of blood is like a hematoma that does not cross the suture line. That is one problem that can occur with forceps or vacuum. The other thing is caput succedaneum, which is a collection of fluid that does cross the suture line. So caput is actually across the entire head, and when you feel it, it feels squishy. If you've ever felt a caput, you just touch their scalp, and it feels like there's water underneath it. That's caput succedaneum. Both of those will actually resolve on their own given time. The problem with cephalhematoma is that when it's resolving, when that blood is resolving, when it's going back into the system, as it's breaking down, it can cause the baby to have jaundice. So it may not be a regular type of jaundice. It may not be from lack of feeding properly, but it's because of the blood supply that's breaking down in the head. There's too much. So yes, it can cause problems. If you think about it, sucking on their head and trying to pull out, it's very traumatic looking. Yes.
And which one is it that causes that?
Both the vacuum, yeah, both can cause both. Now, if you're, of course, going to use a vacuum or forceps with a dystocia, you have to have a lot of factors involved. First off, they have to have a ruptured membrane stuff, because you have to get up in there to the baby's head, right? Their cervix has to be fully dilated. I would hope that you wouldn't pull it out against the cervix that wasn't dilated. And they have to have an empty bladder, and they have to know the type of pelvis before you get started, because all the vacuum in the world is not going to help you if you've got a flat pelvis. If you've got a flat pelvis, you can vacuum all day long, and all you're going to do is risk that baby's head. It's not going anywhere, okay? So you only use vacuum or forceps if there's a dystocia problem, if the mother cannot push, or there's something blocking the way, or whatever. But you cannot use it if it's not going to happen anyway. Now forceps, it's the same principle, except forceps they look like your spaghetti tongs. Anybody ever seen forceps? Okay, forceps look like your spaghetti tongs. You just reach up there, you put one side on each side of that poor baby's head, and you pull, okay? I don't know, there's not one better than the other. Truthfully, they both cause just as much damage. The thing about forceps, though, is it can cause there to be lacerations or tears in the cervix or the uterus. So that is a problem.